Today I'm going to be talking about falls as a geriatric syndrome. A fall is defined as the sudden, involuntary transfer of body to the ground and at a lower level than the previous one. Risk factors for falls include a history of falls, visual impairment, polypharmacy, decreased strength, and functional limitations. Because falls are the cause of significant immobility, morbidity, and mortality in the older adult population, they are considered a geriatric syndrome and a major public health concern. Annually, greater than 1 in 4 older adults ages 65 years or plus experience a fall. Falls are the number one cause of injury and injury related deaths in the older adult population. Annually, falls result in more than $31 billion in Medicare costs. Nurses and advanced practice providers provide care and treatment of these older adults post fall and should play an integral role in screening for the risk for falls and preventing future falls by educating on fall prevention. Polypharmacy plays a significant role in my patient's risk for falls due to her 25 different scheduled NPRN medications listed here. My patient's allergies include adhesive tape, Avelox, clindamycin, penicillin, Stadol, Sudafed, tetanus, morphine, niacin, protamine sulfate, and sulfa. She is up to date on her immunizations and sees her primary care provider regularly for management of her chronic conditions when she is not admitted to a skilled nursing facility. She sleeps around 7 to 8 hours every night and wears her CPAP as well as her seatbelt when she is in the car. My patient has a significant past medical history with multiple comorbid conditions. Some of these include congestive heart failure, COPD, type 2 diabetes, and chronic kidney disease stage 3. She has been hospitalized for CHF exacerbations in the past, as well as hospitalized after previous surgeries. She currently resides in a skilled nursing facility to receive skilled therapy services after a fall resulting in a right femur fracture. A patient who has experienced falls may present with decreased muscle strength, trouble with balance, difficulty walking, orthostatic hypotension, or visual impairment. A patient who has experienced falls may have complaints of lightheadedness, a fear of falls, muscle weakness, dizziness, or pain. My patient denied fatigue, malaise, changes in level of consciousness, vision, or hearing, chest pain, palpitations, shortness of breath, any joint pain or muscle problems, and urinary incontinence. She confirmed a history of falls, a history of generalized muscle weakness, especially in her lower extremities, decreased range of motion in her right lower extremity, and gait impairment due to her femur fracture she sustained from a fall in the past. Subjective and objective data can be used to determine a patient's risk for falls. My patient's pertinent physical exam findings included an incision on her right lateral thigh from her femur fracture repair, generalized muscle weakness to all extremities, decreased range of motion in her right lower extremity. Otherwise, her exam was normal. There is no specific diagnostic testing to determine fall or injury risk, but X-rays, CTs, or MRIs can be used to identify an injury that was sustained from a fall. There is also no specific lab work to determine fall or injury risk, but lab work can be used to help identify an underlying cause or a contributing factor that led to a fall. The screening tools I used to evaluate my patient included the mini mental status exam, on which she scored a 25, indicating no cognitive impairment, the clock drawing test. She was able to draw a clock correctly, indicating no cognitive impairment. The geriatric depression scale. On this, she scored a 6, which indicated depression. Because this was new for her, we referred her to talk therapy services with the facility therapist. We will continue to evaluate the need for changes to the treatment plan after this first session. We also conducted an oral health exam. It was shown on her exam that she had dry lips and dry mucosal tissue. Per the tool recommendations, a dental referral is indicated. I discussed with this patient visiting her dentist upon discharge. In the meantime, we suggested staying hydrated, using lip lubrication, and continuing twice daily dental hygiene. The treatment of falls is based on the injury sustained, the underlying cause, and the contributing factors that led to the fall. Some possible interventions include making environmental adaptations to improve home safety and prevent falls by installing grab bars in the bathtub and beside the toilet, removing throw rugs from the home, and using non-slip tub mats and rugs. Reviewing medications at each visit and reducing the number of medications that the patient is taking if possible. Strength, balance, and endurance exercise to increase muscle strength and prevent frailty through home based or group based exercises or physical therapy. Differential diagnoses for falls are based on underlying cause and contributing factors that led to the fall. Potential underlying causes could include syncope, orthostatic hypotension, deconditioning, cognitive impairment, and gait disturbance. Differential diagnoses for falls can be ruled out through physical exams, cognitive screening tools, balance and gait tests like the Get Up and Go test, and diagnostic testing. The final diagnosis for this patient is generalized muscle weakness and deconditioning due to the patient's muscle weakness in all extremities and decreased range of motion in the right lower extremity. Challenges to the treatment plan include inability to afford home safety modifications, inability to decrease medications due to complicated medical conditions and comorbidities, and inability to adhere to an exercise regimen. Resources for patients who have experienced a fall or have a high risk for falls include community fall prevention programs that help teach older adults fall prevention strategies, as well as group exercise classes geared towards senior citizens to help motivate older adults to get regular exercise as well as socialize with other older adults. Some patients who have experienced a fall or have a high risk for falls may need durable medical equipment like a walker or a cane as well. Multidisciplinary health team resources include physical and occupational therapy services. Health behaviors identified in this case study include sedentary lifestyle, polypharmacy, and multiple comorbidities. Social determinants of health for this patient include adequate access to health services as well as access to clean, safe living conditions due to current status as an inpatient in a skilled nursing facility. Socioeconomic issues for this patient include whether this patient will be able to afford long-term care if it is determined that the patient is not appropriate or safe to return home after skilled therapy stay is complete. Ethical issues identified in this case study include whether the patient will be able to adequately take care of herself at home once her stay as a skilled therapy patient has ended, or whether she will need to transition to long-term care. This is based on her progress in PT and OT, the provider's judgment, and the social worker's assessment. All of these interdisciplinary team members and the patient work together to make this decision. Throughout researching for this presentation, I learned that there are multiple risk factors I was previously unaware of that contribute to the risk for falls. Even the fear of falling can be a risk factor for falls, as this fear can cause older adults to avoid certain activities that they believe could lead to a fall, which in turn limits activity, leading to a sedentary lifestyle, and muscle weakness, which creates an even greater risk for falls. I also learned that it is important to ask all adults, regardless of health status, not only whether they have experienced a fall in the past, but also whether they have experienced tripping or near falling in order to get a better idea of their risk for future falls.